Good morning, everyone, and thanks so much for joining us for QI Power Hour. This is Tracy Sharon from the Saskatchewan Health Quality Council. For those of you joining us for the first time, QI Power Hour is a free monthly webinar learning series hosted by Health Quality Council. We bring together improvers from a variety of sectors with an interest in improving health and learning about quality improvement related topics. I am joining you today from HQC's offices in Saskatoon on Treaty 6 territory and the homeland of the Métis. At the Health Quality Council, we serve the entire province of Saskatchewan, which also includes lands that are on Treaties 2, 4, 5, 8, and 10 as well. As treaty people, the staff of HQC are committed to working with Indigenous peoples in a good way and are also committed to doing our part in working toward reconciliation. To learn more about the actions we are taking and to hold us accountable for our progress, you can see our plans and our Caring for Culture blog on our website at saskhealthquality.ca. While you're there, you can also look at past QI Power Hour sessions. So these sessions are all recorded and posted on our website for you to view at your convenience, and we'd encourage you to do so. You can also sign up for our QI Power Hour email newsletter and then receive notices about upcoming sessions and details on how to register straight to your inbox. So please also sign up for that while you're on our website. We are very excited to see the continuous spread of QI Power Hour throughout our home province of Saskatchewan, across Canada, and around the world. And so we just really want to thank you for spending an hour of your time with us and for your dedication to continuously improving and learning about the systems that you are each a part of. We would very much encourage your active participation in the session today using the chat function. So if you've never used that before, there's a little speech bubble looking button near the bottom right-hand corner of your screen. You can click on that and share your questions, your comments, and your ideas. Make sure you set the two in the to box to everyone so that we all get to see what you're saying. And I see that several of you are already sharing in the chat about who you are and where you're joining us from. So I'd encourage you to continue with that. Share your comments and your questions in there as well. We should have a bit of time at the end for some questions, and I'll be monitoring that and bringing those forward at the end of the session as well. So now on to our presentation for the day. I am very excited to welcome Dr. Ginger Ruddy to talk to us about the patient's medical home. Dr. Ruddy is a Canadian family physician who trained at Baylor College of Medicine, the University of Washington, and Georgetown University in the United States. She worked there for over 15 years before happily coming home. She has also had the privilege of working in a range of different health systems in Latin America, Africa, and Asia. She divides her time between working as postgraduate faculty in the Department of Academic Family Medicine and directing the Office of Student Services for undergraduate medical students on campus. She has worked with the Saskatchewan College of Family Physicians and the Saskatchewan Medical Association, advocating for the patient's medical home, and is part of the Primary Care Compensation Working Group, striving to change how we provide and pay for medical care in Saskatchewan. So a very important topic for us to learn about today, and I'm very pleased to welcome Dr. Ruddy. And please, Dr. Ruddy, take it away and share your presentation.
Thank you so much, Tracy. I appreciate that. And good morning, folks. I'm delighted to be here and optimistic that I can figure out how to manage the tech. We'll find out how that goes. Currently, I'm not able to advance slides, so I might lean on our HQC staff for assistance with that. And while they're organizing that, I'll just talk a tiny bit about, oh, there we go. So the patient's medical home. This model is one that came out of the American Academy of Pediatrics about 40 years ago now as an approach to figure out how to provide optimal care to the sickest pediatric patients, those with complex needs that really needed wraparound care from a team. And it has since expanded into family medicine. And in the States, it's usually called the patient-centered medical home. And here out of the Canadian College of Family Physicians, we call it the patient's medical home. And we're going to talk a little bit today about why I think that this model is a part of optimizing care in our province so that physicians can provide the care we would all like to, and so that patients get what they need and deserve. So In 2019, the CFPC updated the patient's medical home model, and this cartoon of a house is how they decided to express it. The foundations, those dark blue characteristics of the patient's medical home at the bottom, are things that we require from our provincial partners and leadership. So infrastructure, the capacity to connect the care in a meaningful way so that people don't fall through cracks, because the cracks in fact get smoothed over. And finally, administration and funding. And we'll talk about how that would look in a highly functioning medical home. Then the center section, functions, is really about how it feels on the ground to be working in a patient's medical home as a physician and to be experiencing it as a patient or a family member. So care in a patient's medical home is accessible. It is centered around patients and families and their needs, and continuity is key. And then finally, that care is comprehensive and based in a team so that patients do as much of their care in one place that is convenient for them as possible. And this care is socially accountable. It adapts to community needs and is not some cookie cutter that is applied universally everywhere, but one rather where patients and their physicians collaborate together to figure out what the community requires and what will make it work best, and then have the resources to implement that. Finally, the roof and what protects us from the rain is this ongoing development component, which is QI and research and ongoing measurement, something that we are going to need to do some changing to implement more thoroughly in Saskatchewan. And then this ongoing CPD, which is for physicians, but also for the staff in the clinics and the supports that are around the physician so that it can continue to work ideally. So every patient's medical home in this ideal world is inside a patient's medical neighborhood, which in Saskatchewan is probably closest to what we've been for the last 5 years or so hearing about in terms of health networks. It means that every clinic is effectively linked with long-term care and home care. They're linked with those community supports that so frequently influence patients' needs more powerfully than we can with our 15 minutes every few months. It's connections with all of our colleagues in pharmacy, in specialty care, in the lab, in the hospital, and in mental health and addiction services. So it's, and I guess the thing that I'm saying is, granted, we have all of these pieces right now, but having now been back in Canada and practicing for about 6 years, what I'm finding is that the connections from each of those to that patient's medical home in the center are not as thick and strong as they are in this cartoon. And I want to show you how I think we can benefit if we can achieve that. So we're not there yet. There is some work to do, and in good news, it really does feel as though both the Ministry of Health and some members of our government are beginning to understand how necessary it is in order to improve care. So looking at a little bit of data out of CIHI, it turns out that in Canada, having universal healthcare like most other developed nations, we are unfortunately not optimizing yet. Less than a quarter of Canadians that were surveyed said that there was a team taking care of them that even had two people. Most people identified their family physician, but didn't identify anyone else as someone regularly involved with their care. And what that means is that that feeling of working at capacity that all family physicians are currently describing in Saskatchewan is heightened and worsened. Whereas if some of the care that doesn't actually require an MD to complete could be completed by nurses, social workers, chemical dependency counselors, etc., then the physician would have increased capacity to provide more care to the patients that they have and to provide care to those additional folks, that 1 in 5 people in Saskatchewan that don't currently have access to a doc. Unfortunately, in Canada, only about 1 in 25 patients said that they could email their clinic with a medical question, and that's just because the build outs for our electronic medical records that would be required in order to satisfy HIPAA requirements are not fully implemented. And we know that when we actually dig into it, many patients would like the ability to email with their or text with their physician, and that in systems in which patients are actually allowed to do that in a private manner and physicians are compensated for that time, many times a patient visit can be avoided, and then patients who actually more acutely require an in-person visit can get it instead. So there's some room to improve there. And finally, and we've all experienced this unfortunately, about 20% of the time in Canada, it turns out that when a patient comes back from a specialist expecting me to have the investigations, the results of that visit, that information hasn't made it to me yet. And especially I find now that we have a patient portal in Saskatchewan, patients think that I can see what's on there, but of course I can't. And so there are connections to be made that we haven't achieved yet. So forgive my not great ability with a highlighter. However, what I wanted to highlight here is that amongst Canadian provinces, not territories, Saskatchewan has consistently had the lowest density of family physicians per 100,000 population for the last 30 years or so. And yes, some of that has to do with things like weather, but it also has to do with the fact that we are still very much on a fee-for-service model of payment, and that complicates one's ability to provide optimal care, because it means that all of that additional work that we do is off the sides of our desk after hours, and it makes things suboptimal. So unfortunately, amongst Canadian provinces, we are also amongst the highest in terms of lack of access to a family physician. And that number since 2019 has unfortunately gone up because, as we know, retirements among physicians have more than doubled since the pandemic began, and then the rate of physicians decreasing their number of work hours per week has quadrupled. So there is increasing pressure, and whenever someone says to me, oh, but Saskatchewan's not in crisis like BC or Nova Scotia, I say, oh, but we are. And I imagine many of you know that, so I will not belabor the point. So one thing that I think that we can do better in Saskatchewan is making sure that people understand what family medicine is and how it works. No, it's not as front of mind as emergency room visits or hospital stays, but it is unequivocally the foundation. And I really liked this that Alberta put out, making clear that while there are tens of thousands of touch points with the healthcare system every day, more than half of those are always with family physicians. And whether that's in the community, in the clinic, or in the hospital, family physicians are the bedrock of our system. And if we are better supported, we will be able to do better by our system and by our patients and by our community. The other thing that I liked is that in Alberta, they are doing a good job of communicating both to patients and to physicians how additional funding achieves additional services for those patients. So in the PCNs, which are the Albertan version of health networks here in Saskatchewan, they get a certain amount of money per patient in that network each year. And they use it for things like expanded out of hours care, because it's a whole lot easier to offer consistent evening and weekend care if you're sharing it with the people who are members of 10 clinics instead of just your own clinic. It's a whole lot easier to augment access and to provide things like the workshops that they're describing here are actually for patients and their families to better understand chronic illness and how to thrive while living with it. And then they also use those monies to hire and maintain additional members of the healthcare team. So if my clinic isn't big enough to support a full-time dietitian, which makes perfect sense depending on where I am, then perhaps we share with our network and we have that dietitian one day a week. And we have access to them on the other days when they're actually rotating through other facilities in the community. So we're a little shy of family doctors in our province now. The number is well over 600 docs short. And if you go on SaskDocs right now, there are actually a couple hundred positions posted, but That is often because many of those facilities actually require more than one physician. And you know that the advertising of physician jobs isn't, unfortunately, commonly matched to the actual reflected need. With these numbers going up, we have to figure out how to make this a place that people want to practice and can practice successfully without burning out, without feeling frustrated at their inability to provide the kind of care that they've been trained to offer. So these health networks that have had their development somewhat stalled by the pandemic, and which development is picking up again, have the potential to achieve a lot for us here in Saskatchewan. They are explicitly meant to be networks that have family physician leadership, and where each community or network is allowed to identify their needs and then work with the SHA in order to meet them, rather than having some universal model layered onto them. So in terms of how health networks work and are evaluated, CFPC has pretty great guidance in terms of figuring that out, because some version of health networks is spreading across our nation. When you look at this list of different approaches that we should be using, you can recognize that we're not there yet. Historically, we've had limited alternate payment plans, or APPs, here in Saskatchewan, but they haven't been available to everyone who wants them. And that, as people graduate with absolutely no interest in working in a fee-for-service environment, is causing more challenges with recruitment and retention. Interoperability is key. In my dream world, certainly we have a single instance EMR where we can all see all of the information on all of our patients province-wide. That's probably not going to happen, but interoperability has been achieved in other contexts where, even if they're working with over 20 different systems, they have a central data mall where all of the sort of translating is done, so that flu shot in Citrix looks exactly like a flu shot in Accuro or in MedAccess, so that you can always find the information you need. Imagine if referrals were standardized and pooled and electronic and reliable. Imagine if we could assess health outcomes and figure out where we were able to make a difference and where we weren't, and what differentiated between those situations where we were being successful and not successful. And then this ongoing reporting and improvement is a feature that we're really hoping that both SHA and ministry understand will be essential, so that we can optimize what health networks offer our people and then what they can achieve in every clinic. So when we look at the Saskatchewan Health Plan from the Ministry of Health for the coming year, in good news, their goals align very strongly with the patient's medical home. And if we are able to align and make the case that we should be investing upstream in family medicine and community-based care in order to save money downstream with less crowded ERs, less crowded hospitals, then I think we'll be making progress. So as you can see, I'm really in favor of our developing high-functioning teams based in clinics, and in having them be high-functioning enough that we can actually keep our complex patients healthy and out of house more commonly than they end up bouncing back into in-house care. And then, of course, this top of scope deployment is really essential, because it turns out I am terrible at administration and clerical duties. I'm also a terrible social worker. I do not have the training for either of those tasks. And when I do them, one, it's a waste of one of the more expensive members of the team. And two, it's done less effectively. And then my time is taken away from providing medical care to people who require it. So this top of scope functioning really can make a huge difference in our ability to get where we want to go. Our health ministry is also excited about cultural responsiveness. Well, we know that happily there is ongoing and improved investment in our health workforce, and it's increasingly going to be representative of our population, because we know that patients unequivocally feel safer when they encounter members of the healthcare system who resemble them, who might have some shared experience with them, and And also they are happier when they can get the care that they need in their home clinic, as opposed to having to navigate a new place, figure out parking, arrange additional childcare because they have to drive somewhere else. And so we're hoping that we can get the right supports in clinic, because that's what patients tell us would be helpful. Finally, our health ministry says they're going to be investing in healthcare infrastructure, which will be really exciting. And it'll look like all of these things: improved staffing, improved access to that health information, and improved capacity. In good news, though, it doesn't require vast investments in entirely new people. What it may require, though, is some redeployment of some of our resources in the province so that they are in places like family medicine clinics, where the flow of patient traffic is actually very high, and where it's probably easier to induce someone to follow up with social worker or diabetic educator, because they're already going there, than it is to tell them that they need to go to a different place. Finally, one of our goals is this responsive mental health and addiction services. In some of the highest functioning patients' medical homes that I've had the opportunity to see, mental health and addiction services are actually embedded in primary care. Very frequently, there's a behaviorist who is associated with a small team of family physicians and who doesn't have their own schedule, but rather is invited in after the physician has spoken with the patient and identified that it might be useful to talk about a particular parenting challenge or family stressor. And the evidence there is that it really reduces the stigma that patients associate with family medicine, because you're just talking to a member of your healthcare team. You're not going to the counselor. And so in doing that, hopefully we can achieve better mental health care for our patients, so that when they do require that inpatient capacity, which will hopefully also be increased, then they will get what they need. So why do I keep harping on about the patient's medical home? Well, because it works. If fully implemented, it achieves better healthcare outcomes, especially for those chronically ill patients with complex comorbidities. It reduces cost of care, and we'll talk about how in places where that's been shown. It also results in an improved patient experience. Heck, we want our patients to feel safe and cared for and trusting of the system in which they're functioning. And it improves staff experience. And wouldn't you love to come home feeling like you'd had a productive, effective day and you're tired, but not entirely out of gas, so that you can enjoy the people that you come home to? So this is why I'm so excited about this model, because if we do it right, we make a difference. So in patients' medical homes, when they are implemented, access does improve in primary care, which means that there is reduced downstream flooding of ERs and inpatient settings. And that was true for all patients, but in 1/3 of those studies, it was even more true for those patients with chronic disease. And certainly those are the ones that we would all love to figure out how to keep healthier and at home. And in a world with a functioning patient's medical home, 4 out of 5 patients could get a same-day appointment with their care team. That's the important piece that I should mention. Anyone can get care in an urgent care clinic somewhere in Saskatchewan today, but we know that the care is better, less costly, involves less duplication, and is faster to reach diagnosis if they see a member of their care team who has access to their entire history and knows them. So our hope is that if we can implement patient's medical home, we can improve people's access to care. I talked to you about improved health outcomes in the PMH, and quality of care gets better. It just does, because instead of me doing my quality improvement work off the side of my desk, it's actually recognized as a paid part of what I am contracted to achieve. So there is time to look at the proportion of my patients that have had appropriate cancer screening and identify opportunities to reach out to them and engage them. And no, all of that work does not fall on the shoulders of the physician. It's actually coordinated by the physician, but implemented primarily by MOAs, who do not have to have extra training to be able to do that, but are rather implementing either letters or calls or appointments in order to get those folks in so that they can have the education and learn about the screening that they need, for example. Similarly, there's really good evidence that people living with chronic disease, and not just those that we have CDM-QIP stuff for, but also those living with mental illness get improved outcomes if they have this healthcare team wrapped around them. Because that means that even if their doctor isn't in clinic that day, they can call the team and say, okay, hey, I'm struggling. This is what's going on. This is what's been happening with my meds, with my context. Let's figure out a plan. All of us would rather that than having someone decompensate so badly that they end up going to the emergency room. So that really excites me. Prevention and screening significantly improve in patients' medical homes. And again, better implementation equals bigger differentials from non-medical home to medical home. And what was exciting for me is that in low SES settings, in places where patients are most affected by social determinants of health, you get the biggest gains around prevention and screening for your patients if you implement a PMH. And when I think about it, so many of our patients who are struggling with poverty and other significant social determinants of health challenges, they're fighting to survive. So prevention and screening are not really high up on their priority list. But in wraparound healthcare, we can make it easy to access those services so that they are things that can be handled while you're putting out whatever the most active fire is for that patient that day. And it means that you get earlier diagnosis of these things that can obviously cause such difficult consequences for our patients. Patient satisfaction gets better. These results are from, there's a page on evidence about the PMH on the CFPC website, and it's open to everyone. It's available to the public, and it summarizes studies over the last 20 years, and it's updated a few times a year. And patients are excited in a patient's medical home that's fully implemented because they can access not just their family doctor, but the other docs they might need. They also explain, the overwhelming majority of them, that they understand their healthcare conditions better. And some of that relates to, as we can imagine, increased time with your doctor if that's the time you need, or increased time with a nurse or health educator if that's what you need. They also reported that they were better able to self-manage, and certainly all of us would prefer that our patients have agency and feel able and competent to manage their care. And people reported they had enough time with their doctor, which is just ludicrous. Having worked in fee-for-service in Saskatchewan, I remember the time pressures, and I remember thinking, okay, but I can't ask this person to come back 4 different times for the 4 other problems that they have, because they can't take 5 half days off work for 5 different medical problems. So there was always that tension, trying to address everything that they'd taken time off to be with me to address, while also making sure that I didn't run late and keep the other 20 people that half day delayed from getting back to their lives. Finally, as you can see, there's significant improvement in patient satisfaction in physician satisfaction as well in a patient's medical home. And that makes me excited when we look at the current levels of burnout in our physician community, when we look at the current levels of satisfaction that we're currently seeing. And we know that when learners are introduced to a PMH in training, then they choose that on graduation. They would strongly prefer to continue to work with a team as opposed to in isolation. And we know that where patient medical home clinics have been rolled out in not all settings yet, but in a range of settings in some other provinces in Canada, recruitment and retention ease. Because in Saskatchewan, we are actually pretty great at recruitment, but we are struggling with retention. And I like anything that says, hey, there's evidence that you can have an easier time holding on to satisfied docs if you do it this way. So I wanted to share this with you because this is 2 instances of PMH being implemented next door in Alberta, where they demonstrated pretty impressive cost savings. The Tabor Clinic is a single source of healthcare for that community and its surrounding catchment area. And the Crowfoot Village Family Practice is a large clinic in Northwest Calgary that is obviously part of the urban setting where there are tons of different resources that are spread all around. And in offering this team-based care that resulted in patients being better managed, especially with chronic or complex disease, they saw that they were able to save huge amounts of money. So in Tabor, it's $449 per patient per year that is saved. In the city, it was still $182 per patient per year. And then the savings over 10 years in Tabor compared to other facilities that they deemed to be comparable in the province, they saved $62 million. And at Crowfoot, they saved $57 million. This is significant, right? It's impossible to suggest that this isn't significant. And it suggests also that we can do it not only in urban settings, but in regional and rural settings. Tabor is not a giant community in spite of their excellent corn. And so our hope is that if we can make this case and say, yes, there is some upstream investment, and that is a pain because you have to figure out where to take it from, but it's worth it because the downstream savings significantly outweigh the investment. So just wanted those numbers to be giant because they're really exciting to me. That's money that matters. And that's money that would allow us to do some of the other things that our healthcare system has been too strapped to do. I'm also going to share an example of a PMH in New Brunswick that is actually a completely fee-for-service model. So the Clinique Médicale Nipissiguit has a team that they have built using really deliberate, careful billing, and then having the physicians elect to use some of their increased billing based on having increased billing support to hire additional team members. And the results that they achieved were kind of astounding. Like when compared to other patients across New Brunswick, their patients were using the ER 38% less. They were hospitalized 20% less. They even were using primary care less because it turns out that if you can get what you need from another team member or via a phone call or email, then you might not need the in-clinic visit. And then that means that that clinic has more capacity to offer to additional patients. Excitingly, and this is stuff that I think actually gets the attention of some of the people in ministry who are managing the purse, they also found that with this wraparound team care that involved continuity and consistency, there was reduced lab and imaging ordering compared to other clinics in the province. We know that this is true about continuity. It's why family physicians end up in family medicine when they choose comprehensive care. But it's nice to see it borne out. And so over the last 20 years, they've demonstrated, significant savings for the province from one clinic. And it's $1,000 per patient per year that they're spending, or that the system is spending rather, less than they're spending on patients at other clinics. I just like this example because it is helpful for me to see it is possible in a fee-for-service environment. That said, I promise I'm still working with the working group, and we are working very hard to provide other alternatives for those physicians who want them. So cool stuff is already happening in our province to advance the PMH sort of ideals and model. Let's look at that a little bit. So the foundations, that navy section at the bottom of the house, we are getting investment, and you heard in May from the ministry that they are committed to facilitating a change in how family physicians are paid, recognizing that right now a lot of the work that primary care is doing is actually unpaid work, and that's contributing to earlier retirements, reduced work hours, and difficulty in both recruitment and retention. There is increased investment both in the SMA and at the SHA around this question of interoperability. Given that we're fortunate and we only have 2 EMRs in ambulatory care settings in our province compared to the 30 or more that are in each of BC and Ontario, this isn't going to be as complicated as it is in some other contexts. And it's exciting that people are finally understanding the patient safety implications of having access to the right information. And finally, the college and the College of Family Physicians, as well as the College of Medicine, are both collaborating with the HHA to work on how we augment specialty care and appropriateness of referrals, as well as appropriateness of information provided back to family physicians following a specialist interaction. And so there is recognition, and this stuff is happening. And if we can unsilo it and connect it, we can get to where we'd like to go. So in that central area, in functions, obviously, one of the major favors that COVID did for us is it gave us the virtual visits that physicians in this province had been fighting for over a decade. And we know that patients are more satisfied with them, and we know that in many cases they're really helpful because If I can have a short virtual visit with someone, then I still have additional time left in my schedule when I can see another person in person whom I would not have been able to see. Um, Something else that happened briefly during the pandemic was open access scheduling. And having worked in contexts where this has been implemented, I will say that I'm hopeful that we can find our way back to it. Remember at the start of the pandemic when everyone's schedules just collapsed because it didn't matter that you had people on your schedule, you couldn't see them. And so you were instead scheduling virtual visits within a day or two of when patients needed them. It turns out that when that happens, once people get used to it, you save a certain proportion of your visits to be scheduled ahead of time and a certain proportion that will be scheduled in short order. Patients are much more likely to see their own physician or team and get that continuity that we know improves care and reduces costs while improving outcomes. Um, Other things that are happening in some settings that we hope to be able to expand if we start paying physicians for all of their time is stuff like huddles. Um, Huddles are happening in hospitals, and we know how effective they are. And if we make it possible for those to happen in more clinics, then we're going to be in a position to have that chat in the morning where we say, oh, I noticed that this patient of mine, this patient of yours rather, is on my schedule. Would you like me to see someone that you're seeing who's not your patient so that you can see your patient? Taking time to do that in a clinic with 15 or 20 docs can dramatically alter the care that's offered and really improve it. It can also say, oh, you know what, so-and-so's coming in and I know that they're dealing with some additional stuff. What else can we do for them while they're in the building so that it's a one-stop shop and they don't need to return? Um, and so this blended payment model that we're moving toward, we hope, will mean that docs are not the only person in those huddles being unpaid, but rather are another team member who's being recognized as providing important work. Another example that comes to mind where um, that blended payment will be really helpful is, for example, in talking with um, personal care homes or long-term care homes. I love at the end of the day when I come and I have 5 messages from long-term care homes, but I didn't finish seeing patients till 6. So the fact that they've been gone since 4:30 isn't really working. And if instead we build in a time during the day when I'm going to interact with all of the people in the community who are also caring for my patients, then we can make sure that care doesn't get delayed, that it gets addressed quickly, and hopefully we can keep them well and in their place of residence rather than having them have to come into clinic a week later because they're sick and we couldn't connect because our hours didn't line up. Finally, there's cool work happening with regard to ongoing development. Um, Finally, our medical school class has been expanded. We went from 100 to 104 students this year. Next year, we're going up to 108. Are those increases giant? No. But they are matched by increases in physio, in nursing, in pharmacy. And so hopefully over time, we will start to be a place that grows our own healthcare providers and doesn't always have to poach them from other places. Not that I am not extremely delighted that we have so many physicians who come from other places to work here in Saskatchewan. But I feel like the fact that we are so dependent on taking people from other systems where they are also needed reflects the fact that we're not producing enough of our own yet. So I'm excited that that's occurring. We are working harder to make sure that physicians are actually paid when they teach in the community, because right now, very commonly, a physician will undertake a significant cut in pay in order to work with a pre-clerkship, clerkship student, or even a junior resident. Yes, their pay may be equal or slightly higher if they're working with a senior resident, but there shouldn't be a punishment for taking on the important work of increasing our workforce. Um, Physician panel reports are now coming into their 3rd iteration, and we're working hard on this process that will connect your panel report with your own EMR. And so QI in Clinics is a new course that's coming out from HQC that's going to be a brief place to focus on developing skills in QI for the whole clinic and on making sure that you can take your panel report from something that uses billing data to something that actually develops out of your own EMR with very accurate data and will allow you to identify opportunities amongst your patients to improve care. There's also been exciting new work around practice improvement essentials, the PLI courses, and then additional work to help physicians and staff, because again, it isn't only on the physician's shoulders to know more about data collection, data analysis, and then the implementation of changes based on the findings there. So good stuff is already happening. We do need more. We need co-location of these teams to a higher degree. Now, that does not have to mean that the person is physically in your clinic. There may or may not be room for other humans in your clinic. Most of our clinics are bursting at the seams. But perhaps there's a day of the week when you have fewer physicians on site, and a couple of those rooms could be used for a couple other people, a social worker or a pharmacist who could come in and offer supports. Or perhaps you could have virtual co-location wherein a particular community diabetic educator is associated with your clinic, and that's the person you call, and she begins to know your patients and their needs, as opposed to getting a different one each time you reach out, so that patients benefit from being known and understood. Blended remuneration is an approach where part of the physician's pay comes from that time that's face-to-face with patients, so that we continue to incentivize volume and the needs of patients to be seen. But as I've indicated, it also remunerates people for the number of patients on their panel that they're responsible for care for, which means that there's some payment each year, which really is about panel management and looking at your panel and saying, oh, it looks like lots of my folks with hypertension are struggling with management or also struggling with weight. Or it looks as though some of my diabetics are seeming to struggle to understand how to implement a diabetic diet. Okay, let's implement some group visits where people can learn about that, or let me have those individuals come in so we can tweak their medication regimens. It's about paying physicians for more of what they do and acknowledging that so much of the time that you spend in patient care is not whites of the eyes time. Finally, and I know I'm harping on this, we need interoperable medical records. I need to be able to see what's happening in the hospital when I need to, without having to go there and chase it down. Physicians in hospital need to be able to see my clinic notes and up-to-date information without having to call and request it. And for example, pharmacy records where immunizations are provided, where prescribing has been offered, need to be something that is shared with the MRP automatically, as opposed to being something that happens if you're fortunate and that clinic is on top of it. Patients are safer when we share information. And I can tell you the transition to that system when I was working in Seattle was deeply painful, but also once it had happened, it was really exciting. I could see someone's echo from 3,000 miles away and last year and know what we were looking for and know what we had to arrange for this year. And I could see their hospital notes and understand what was needed for them and how I needed to connect them with additional pieces. So it turns out that happily the Cochrane folks have done a systematic review and figured out that blended capitation both improves access and results in those downstream savings. Things like fewer hospital visits, fewer repeat prescriptions, because there is in fact better coordination of care. And then we know, for example, that if you use salary or capitation as part of that blending, something where there is a recognition that lots of the care is not whites of the eyes, that quality of care is improved. It turns out that if you're rushing and you get 6 to 8 minutes with each patient, you're putting out fires as opposed to digging into complex issues, looking at prevention, looking at screening. So the evidence is pretty strong that blended capitation and blended compensation will improve care for patients as well as outcomes and satisfaction for docs. The people who benefit disproportionately from this kind of care are vulnerable populations. And we know that they're the ones who, one, need it the most, and two, currently are using the most healthcare resources, but not in ways that improve their health and their experience of life. So that's who benefits. And rather than creating a system where some physicians are paid one way and some are paid another, and they don't have a choice, so people end up cherry picking the patients that fit their model best. Our hope is to try and offer a blend so that, yes, you're encouraged to see patients in volume so that you can earn additional income, but also the pressure to see them rapidly is taken off so that if someone's life is imploding and you need half an hour with them, you can take it. Chronic disease management gets better when we pay people in a way that doesn't rush them. And especially when it's our folks who are struggling with the social determinants of health, having negative impacts on their health, we know that this approach will allow them to have the time that they need. It will allow them to have the supports that they require to work around a more complex social situation. And it will allow the kind of teamwork that will mean that they can stay well and stay with their families at home or at work and not have to have things derailed by having to go into hospital. I love the idea that quality improvement in a patient's medical home is a core activity. You're always looking for, hey, how do we make this better? And in the vision that we have and that we've shared with ministry, QI time is paid time because you are in fact improving care for your patients in that time. It should not be time that's used in the evening when you could be having dinner with your family. It does mean that we will have to do a better job of data collection. So rather than just picking the code for hypertension, because that's one of the 7 things you talked about in the visit, and having that be the only thing on the bill, we're actually going to figure out how to make sure that we capture the complexity that patients are of the care that physicians are offering to their patients so that we can identify what care is getting offered, where we should be investing more, et cetera. Because it turns out that the 4th, 5th, and 6th topic that you discuss in that visit are probably as important as the first. But right now, we're not collecting that data in Saskatchewan, and it matters. Because in British Columbia, they have 20 years of complexity data, and that has been part of what enabled them to roll out their new system of payment of family physicians so quickly. And so we have to start collecting that data if we're going to be able to make the case, which to every family doc is very true, that in fact, I'm not seeing one diagnosis per visit. I'm actually caring for a range of things, and those visits where I'm caring for a range of things need to be different than a visit where I'm doing a medication renewal with no changes. Finally, as I indicated, we know that you engage all of the staff, not just docs, to do this QI work. And in situations where this has been rolled out, where I've been working, it's been really exciting because our medical office assistants went from feeling like they were clerical staff to feeling like they were integral members of the care team, which of course they are. And so they were the ones calling and saying, gosh, I noticed that you haven't gotten your mammogram yet. Can I help you set that up? Where would be most convenient? They really began to invest in themselves as members of the care team. And both they and patients were happier about that. And then we also found that we were doing a lot less recruiting and training of new folks because our folks were sticking around longer. So sometimes when you're doing QI in a PMH, sometimes it's just, I'm going to pick one thing and I'm going to dig into that and do some PDSA cycles. Then I'm going to share with my colleagues what didn't work, what did work, and where it might be scaled for our larger group. And it begins to be something where instead of feeling like something overwhelming that I have to do off the side of my desk, it becomes something that's small and manageable and supported that I can roll out and then share with my colleagues so they don't feel like they have to invent the wheel. They can go, oh, let's try Doug's project because he was able to increase his fit testing rates by 20%. So I don't know what magic he did, but we need to roll that out because then we can identify our patients who might be in need of additional care for that. Another way that it works is where you get a report every 2 weeks. And that happened in my last clinic in Seattle. And I could see for every one of my colleagues whose screening was up to date, whose vaccinations were up to date, whose range of chronic disease management metrics were in line. And it was helpful because the reports that were run showed for a specific patient all of the things that they needed. It was called the super list. And it meant that rather than having to dig through 17 different lists, I could say, oh, this guy requires a nudge about his tetanus update, but also a reminder about the fact that he's due for his low dose CT for his smoking screening. And then we need to see him in about his diabetes. And this information was run through reports that were just built into the EMR by our skilled EMR experts. And it meant that that information was made available to us. So when we started the day with every patient that we looked at, as we huddled and looked over our lists, we knew what we were going to highlight with them. And then when I opened the EMR, there were little reminders about the specific things that were required for that patient. And this stuff is available in the 2 EMRs we currently have in our province. And in my vision, the ministry recognizes that and does that in additional investment so that our EMRs can actually do the tasks that they're paid to without having to cause yet more out-of-pocket expenditure from community physicians. So right now we're spending over $7,000 per year per person in Saskatchewan on healthcare. If we just put less than 1% of that toward primary care redesign, it would actually be significant and huge. Those are the kind of amounts that they're using in Alberta to create PCNs. And they've been able to achieve the kind of results that we know will make a difference. So I'm arguing that we should invest in ourselves, and I hope that I've made the case to you that it's worth considering. I'm going to pause there and invite questions, and Tracy, I'm going to count on you to moderate that. Thank you so much for your attention. I hope that it made sense. I'll stop now. Thank you.
Excellent. Thanks so much, Dr. Ruddy. So much to think about in there, and such an important topic, I think, for us to consider as a health system to support the health of our population. So I haven't seen any questions pop up in the chat yet. So I'd really, we have a couple of minutes. We have time for a couple of questions. If you have one, please feel free to pop it in the chat. Maybe while you're thinking, I've got one that I could ask. So you talked about, I really appreciated the diagram of the house, outlining all the different kind of levers we have to put in place to support a patient's medical home. Some of them seem kind of really system level. So things like interoperability, like remuneration, like evaluation, like quality improvement, and might seem, for individual, physicians or clinic teams, something out of their control. So I know you gave some examples of changes, clinic teams had made themselves, but and we talk about an improvement, small tests of change like you did, what could we do by next Tuesday? So what would you suggest for, a clinic team that's listening to this, that's like, hey, we want to do this, where would you start? What kind of small changes could they start with?
Thank you so much for that question. What I would agree, absolutely. It can feel frustrating because the foundations are out of our control. But I promise you that there are docs who are working our tails off to try and change the foundations, and that if you're excited about it, we would invite you to join us because we definitely need more excited and invested people. On the ground, in the front, sort of on the front line, the things that I've seen that have made the most difference have been this using this, I'm going to try and get a sentence out here, have been figuring out how to use our EMRs in the ways that will allow us to gather this information. And so it might mean connecting with the EMR team from the SMA, which is a service that we all pay for, in order to say, hey, I've noticed that I'm having lots of patients who are smoking or vaping more, and I want to see if I can get a sense of who that is and how I might intervene in that way. And because once you learn how to run the reports in your EMR, it actually gets quite straightforward. And again, it won't have to be a physician who does it. It can be your clinic manager or your RN or your skilled MOA. As you know, our MOAs run our lives for a reason. They're incredibly capable. They know our patients well. And if we give them the tools to gather that information from the EMR, it actually provides us with an opportunity to say, okay, I'm going to dig into this. So what I did is I made a letter that I plunked into the EMR as a template that says to a patient, hi, I was reviewing your chart and I noticed that you are due for some medical care that I want to offer you the opportunity to talk with me about. And it checks off all the things that they're due for. And we are fortunate that we have a doc who has an engineering background and who loves figuring out the EMR. And so he's built a dashboard for us where I can see and click and say, oh, who hasn't had their bone mineral density recently? And then when I pull that up, I'm actually also able to see anything else they need. So those places have been places where we've been able to actually make an impact on measures. Once you select one from your reports in your EMR, go to town on it. And then within a month or two, you can actually see a change.
Excellent ideas. Thank you so much. Yeah, EMRs remind me, of our iPhones or something. There's so much they can do that maybe we don't know about. If we just dig into it a little bit and with a little support, we can get them to do a lot more for us. We've had a few questions come in, which is great. So now I'm going to try to get to them all. So what are your largest barriers to implementing these strategies? So, some examples they've given us: money, government buy-in, physician buy-in. What are some barriers and how might you work through those?
So yes, those are significant barriers right now. Um, One of the things that we're recognizing, especially when we look at places like BC, where they've successfully induced a significant change in how physicians are paid, that was rolled out pretty quickly, we have to get patient buy-in. Patients are the voters, patients are the people who decide if our government has a job next term or not. And so if we can help patients understand what's in it for them, um, then they can get fired up and actually assist docs, because docs complaining about pay, of course, is not something that's going to yield significant buy-in from the larger community. And so in helping patients understand how their care can look different, how it can look better, and having them start to demand better care and care that's pretty widely available in Canada now, I think that's where we can get those other pieces: government buy-in, money. And physician buy-in is a piece of it. And that's why I do these talks whenever I get invited, is to try and help people understand how it can look different. Because all of us have just had our heads down and been working really hard in the system as it exists. And everyone has been making improvements and continues to do so. And if we could harness all of that effort and align the efforts that are being made, then I think we can get somewhere bigger. So we're working on the physician education part, and we're trying to figure out how to get patients to begin to demand it, because that's when I think we get the higher up buy-in.
Excellent. Thank you. We have so many great questions rolling in now, and I'm sorry, I don't think I'll be able to get to all of them. But I'm going to take the second one here. So it's someone asking who feels very passionate about the work that you've described. They have a non-medical background but significant IT knowledge. Maybe don't work in a clinic or for a clinic team, but wants to help. So do you have any suggestions to offer for people who are like, hey, this is a great idea. I'd love to support it. How can I help move this forward?
That's so exciting. Thank you. I feel like it probably makes sense to touch base with some of the larger provincial organizations. So whether it's the SMA or the College of Family Physicians, and say, hi, I recognize that there are significant needs in this area. I have this background, and I know that people would leap at that opportunity to engage with you and to talk about where the gaps are and where they might be filled. Thank you for that.
Great, thanks. So I think we'll do one more. So this is a question about what the physician's vision is of leadership roles between clinic, and I'm assuming that to be kind of medical staff, and SHA leaders, or Saskatchewan Health Authority leaders. So for example, we could better align SHA staff within each clinic in the network model, but need good clarity on roles and responsibilities to move that model forward. So any vision on that?
Thank you. So I'm going to get you to repeat the last part again, Tracy. I apologize.
Sure,
My
no
brain's
problem.
tiddling.
So I think what this is getting at is, the idea of health networks, the idea of
Mhm.
collaboration between, physicians and clinic teams and SHA staff and leaders, what the vision might be for how we achieve clarity on roles and responsibilities to be able to move that model forward. So thinking there's a lot of power there, a lot of opportunity. What's the vision on how we clarify those roles and responsibilities? I hope I got
Thank you.
that right.
Thank you so much. And it is a great question, and not a straightforward one. But I think having worked both in a fee-for-service environment and a non-fee-for-service environment, one of the great luxuries of being in an alternate payment model approach is that members of the team get to sit down together regularly, and have conversations about what their day looks like, how it's involved, how they're spending their time. What would make it work better? And when I was in a fee-for-service context, that could only happen in very limited ways because of the pressures to see patients as quickly as possible. And so improved understanding of how our colleagues are spending their time, I think um, can allow us to figure out where the opportunities are to optimally sort of roll out everyone's capacity, because patients do benefit if we do a better job of that. And it's going to involve a higher level of communication, because I think we're trying to increase interprofessional education in the training pipeline as well. And so I would love it if when learners went out into the community, they encountered not just a physician they were engaging with, but also the other team members, so that we could all begin to understand better everyone's contributions. Hope that helps.
Great, thank you so much. Well, I'm noticing it's 10:30. I've unfortunately taken us very close to the end of time, but we had so many great questions near the end that I wanted to try to get to them all. So I'm just going to wrap us up now. Sorry for the rapid slide movement. I don't know how to make it go all the way to the end all at once. So I'm just going to advance through these really quickly. But I just want to thank you again, Dr. Ruddy, for sharing your presentation and all of this information with us. It's a very important and timely topic in our health system right now. A lot of good change happening, a lot left to go, and I think a lot of really passionate people who want to make this happen. So I think you've given us all some good ideas to think about. So
Yeah.
as a QI Power Hour speaker, as a small token of our gratitude to you for joining us today, you will receive a fancy new pair of I Heart QI socks. So you can watch your mail for those. And for anyone who's listening, if you have a topic you think our audience would like to hear about, we'd love to hear from you as well. And maybe you could get your hands on a pair of these socks as well by becoming a QI Power Hour speaker. So please reach out with your topics to us as well. Just have a couple of last things to say. If you have to go, thanks for joining us, and please do go do what you need to do. But just a couple of things. I know Dr. Reddy mentioned the QI in Clinics program, so we did want to highlight that today as it's very linked to this topic. We do have applications open for our upcoming cohort that will be starting in September and going until December. For those of you who don't know what this is, QI in Clinics is a 4-month learning program designed to build foundational skills and quality improvement methodology with physicians and their clinic staff in primary care clinics in Saskatchewan. So very much linked to what we talked about related to the patient's medical home today. If you're interested, this course will expand your existing toolkit to help meet your vision of optimized care, leading to improved performance, outcomes, and better experiences. So a lot of the changes you heard about in this presentation today, this course can help you identify those changes you want to make and put them into action. So if you're interested, if you think of clinics who might be interested, please share that information with them. And there is a link in the chat for you to check out for more information. We also did want to offer the opportunity to participate in what we're calling a randomized coffee trial. And we've done this before in the past in the province as a networking technique. So if you're wondering about the name, it's a bit of a play on words. If you're a researcher or a scientist or have read about health research or science, you've heard of a randomized controlled trial where study participants are randomly assigned to study groups. This is a randomized coffee trial. So it's a way to connect with someone you might not ordinarily have had a chance to talk to. You sign up to participate and then you're randomly assigned a coffee partner. And then you can arrange a time to meet with that person and just have a chat. You can meet virtually or in person, whatever works for you, and talk about whatever you like. If you need a bit of a prompt to get you started, we can offer a question for you to talk about. And that could be, what do you find most rewarding about your work in quality improvement? Or talk about whatever you like. So if you're interested in participating in this, there's a link being shared in the chat. If you sign up by August 18th, we'll randomly pair you with somebody, let you know who that person is, and then you can arrange to have your coffee chat with them. So it's a very fun practice, a really good way to get to know people you wouldn't otherwise know. I'd highly encourage you to sign up for that by Friday, August 18th. Final couple of things. When you leave the webinar, you will be taken to a post-webinar survey. You'll see a screen like this. Don't be alarmed. It is a trusted site. Please feel free to click through and fill out our survey. We really do read every response that we get and use the data to continuously improve our QI Power Hour webinar. So please do take a few minutes to share with us what we're doing well and what we could be doing better. And finally, please do join us next month on September 22nd from 9:30 to 10:30. We'll have Dr. Gary Groot presenting to us about learning health systems in Canada and what we need to know. So will also be a very informative, engaging topic. And so with that, my apologies for taking us a little bit over time. There was just so much interesting stuff here to talk about. Again, my thanks to Dr. Ruddy for joining us here today. And until next time, everybody take care, and we look forward to seeing you in September.